Good afternoon, everyone. Welcome to Special Topics in Geriatrics, Healthcare, and the Older Patient. This is session 4, medication use in the elderly, and Dr. Cunningham will be presenting today on substance abuse and medication addiction. This is UTMB, East Texas Geriatric Center Consortium, in partnership with the Texas Area Health Education Center East. This award is funded through a HRSA grant, which is an agency of the U.S. Department of Health and Human Services. We're broadcasting this here, and as well, it is being broadcast in Piney Woods, which is at SFA and Victoria College. So those are our partners. Hi, everybody. Wave. Are y'all there? Wave if you can. Wave if you can hear me. Okay, I see somebody waving. Okay, good. All right. Teleconferencing sites, again, today we have Lamar University, and we don't have Lamar University today. We have SFA and Victoria College. Baylor and Weatherford College were unable to join in today. To receive contact hours for continuing education, we're offering continuing education for social work. You must attend the entire program, complete the evaluation, and have no conflict of interest identified. To receive your CEUs for social work, you need to sign in, fill out the sheet, submit the registration form, and complete and submit the social work evaluation. Key points in today's presentation from Dr. Cunningham: alcohol remains the primary abuse substance among older adults admitted for treatment. However, 25 million of older adults use prescribed medications, while an estimated 5 million adults 50 years and older have illicit drug use in the past year. Such addictive drugs corrupt the brain circuits we use every day to make needed changes in our behavior in order to adapt to new and important events. Addictive drugs induce pathological changes in the brain circuit communication that impair an addict's ability to modify or stop drug-seeking behavior. And in this presentation, we'll explore the modern perspective on the neurobiology of substance use disorders. Dr. Cunningham is currently the Chauncey Leake Distinguished Professor of Pharmacology, the Director of the Center for Addiction Research, and the Vice Chair of the UTMB Department of Pharmacology here at UTMB. She founded and created the vision for UTMB Center for Addiction Research, implementing key strategies to expand research and mentoring activities, recruiting high-caliber faculty, capturing philanthropy, and optimizing grant programs. Her laboratory engages in cross-disciplinary translational research with chemists, cell biologists, and clinical scientists who are focused on targeting mechanisms in molecular therapeutics in addiction and related disorders. She's been funded over the last 25 years with NIH research and has been described in 110 peer-review publications and 25+ reviews and commentary. She holds 3 patents for chemical entities with her synthetic chemist collaborators. Dr. Cunningham has mentored 40+ junior faculty, pre- and post-doctoral fellows who've published over 70 publications and received more than 25 grants. She was elected president of the College of Problems of Drug Dependence and was honored with the 2012 CPDD Mentorship Awardee and the 2013 CPDD Marion Fishman Memorial Award. She is an associate editor of the ACS Chemical Neuroscience, a member of the editorial board for Nature Neuropharmacology, and the editor of the 2014 Nature Neurophysiopharmacology Reviews. She's chaired neurobiology and a motivated behavioral study from 2011 to 13 and received an award for translational pharmacology, and is an active executive leadership in the academic medicine program and the Distinguished Faculty Research Award at UTMB. She's an active educator, a member, and a board member for community programs, and works with secondary high school students and colleges in the region. Thank you, and here is Dr. Cunningham.
Thank you for that nice introduction. And everybody, welcome. I see a few people online. I'd like to tell you, I changed the title of my talk, but the idea was, I changed it actually this morning because I realized when I was working on this talk that there is a changing landscape of substance abuse, and I hope to give you a little bit of a background about that so you can appreciate not only the contemporary science that's going on, but also the demographics and the trends in substance abuse. I don't know where to stand to see this. All right, so you saw the flash of the CME key points. This is them over again. Basically, we're going to look at prevalence in older adults, addictive brain circuits, the pathology of the brain, and try to put it all together to think about what the best treatment modalities might be. And this is a changing landscape. So the CDC tracks drug use, and they track drug use all over the world, all over the U.S. And in 2011, the leading cause of preventable illness and death was tobacco use, and the third most problematic was excessive alcohol use. And these are their list of preventable illnesses, and these are only two of the drugs that humans favor in terms of their substance abuse. They also noted that 50% of alcohol consumption is binging, which I was surprised. And for women, that's 4+ for women and 5 drinks for men, over 5 drinks for men in one occasion, usually just in a few hours. 50% of that alcohol consumption is now in binge drinking. And another notable fact is that prescription drugs now kill more people than illicit drugs. We think about heroin overdoses, we think about drugs like cocaine causing overdose and death. But in reality, it turns out that now that the lethality and mortality is in prescription drugs. This is a sizable financial drain on our resources on many different fronts. And I have a slide that says it's $357 billion. You can see all the parts of that, which includes health, which of course we're concerned with. But in reality, that doesn't actually provide a snapshot of what it is to deal with someone who's alcoholic or a drug user. And too many times we are hearing about sudden deaths in young people who have combined drugs and had no intention. They were not addicted, but they had no intention to do that, but they put together a lethal combination. So the cost is important from the perspective of how can we reduce these costs, but more importantly is how can we reduce the health impacts of substance abuse. These are, this is a very brief table of our favorite drugs of abuse. Alcohol is alcohol and cannabis rank up there with smoking, which is a stimulant. Nicotine's the active ingredient in cigarette smoke, in chewed tobacco, all of those forms. So these three really are very high in the level of mortality and morbidity. The stimulant category includes nicotine, cocaine, MDMA, methamphetamine, but it also includes such drugs as those that are taken for ADHD. They're also stimulants. In the last 5 years, heroin use has doubled in the U.S. 5 years, doubled. And that doubling is happening in youth. And so this is a very challenging thing to have happen right now because we were already dealing with prescription medications and challenges with those. And there's a hypothesis that heroin use is on the rise because it's too hard to get OxyContin and other drugs like that because the government has clamped down on those. So opiate use is again rising. Then there's a category of sedative hypnotics, which includes a large class of benzodiazepines and what are classically thought of as sleeping pills or barbiturates. And then probably one of the smallest numbers of users are in hallucinogens, LSD being an example, and mescaline. If we think about these in terms of their licit and illicit nature, licit means that they're legal, and we can categorize these. Alcohol's legal, tobacco's legal, opiates are legal, and benzodiazepines are legal, for example. But the star indicates that they're only legal if you're of the right age, right? There's a legal limit for the use of alcohol and tobacco. Usually it's 18 or it's 21 now. Opiates would be a illicit drug. However, that's with the prescription and with the appropriate indication and taking the medication. Same thing with benzodiazepines. So even illicit drugs can be drugs of abuse. The category that includes illicit drugs is very large. This is illegal drugs. Cocaine, heroin, marijuana, LSD are examples of drugs that are in Schedule I category in the U.S., which means that they have absolutely no medical utility. They can't be given as a prescription because they have no clinically proven value. Now, did I say anything that made anybody wonder what I said? Right. So California and other states have been allowing the use of marijuana for on a prescription basis for medication, and now 2 states have made marijuana legal, Washington and Colorado. I think it's going to be very interesting to see what happens next because it's still a Schedule I drug at the federal level, and now we have state level indicating that they're interested in changing those regulations. When we talk about substance use disorders, there are a lot of different words in this area, and I'm going to try to stick to the words that are used currently in the Diagnostic and Statistical Manual of Psychiatry. Mental health disorders, the current version which came out last year, DSM-5. And the substance use disorders indicate the levels of drug use and impairment associated with that level of drug use. There's always something new on the street, and caregivers, Bob and I, one of my folks in my lab and I just had an experience in which one of these new drugs showed up in the emergency room at UTMB, and they were concerned about it, and they had a green leafy substance, and 3 teenagers who had consumed it and were in the emergency room with some serious physiological symptoms. Turned out when we had our colleague Gia Joe analyze it, that it was a marijuana-like substance that's sold on the street called K2 or spice, and it was the chemical additive JWH018. This is an incredibly toxic compound which has lethality, and many people have died. These kids actually survive and they're fine. It's a synthetic cannabinoid agonist. You've probably heard all of these in the public domain. Salvia is a hallucinogen. It's an herb that's grown in Oaxaca. It's a very potent agonist, causes very short-term hallucinations. And the one that captured the attention of public in the last couple of years were bath salts, which is a term that's the way it was sold. And what was actually in there were amphetamine-like stimulants, and it turns out that after they were beginning to analyze them at the federal level, there were derivatives of cathinone, which is from the plant, the khat plant, KHAT, and there are dozens of these compounds that are easy to make in the garage chemistry lab, and some of them actually have their own levels of lethality and toxicity. So there's always something new coming down the pike, and garage chemists are incredibly creative and can manage to mine the internet for all sorts of that, and that's how this came about. They mined the internet, found Hoffman, who's a chemist. He was making these ligands for therapeutic purposes in a drug company, and they were able to make them. They're pretty simple to make. So lots and lots of words that are used in this area. I don't know how to go through all of them, but I'm happy to answer any questions you might have. But I'd like to start with the term misuse and the ways that a drug can be, or a medication can be misused by a patient. Obviously, they can take more drug than they should be taking. That's one way. They can use it longer than prescribed. They can use it for purposes other than the indication for which it was given. In some cases, the mixing of alcohol with the medication or with the drug or other medication can be quite serious. Skipping and hoarding medication and discontinuing at will or against the physician's orders. So these are examples of misuse. It does not indicate that an individual is necessarily addicted or having problems with it, but there are many ways that a drug can be misused. But this also happens at the practitioner level, which is something we don't connect with necessarily. Failure to monitor the appropriate use is an example of this use of medication. Failure to explain the appropriate use. How many times have we all wondered why we had a medication in a bottle at home and we weren't quite sure what it was for or how to take it? That is obviously inappropriate. A prescription for an unnecessary high dose of a compound or medication and a prescription for an inappropriate indication. These are called off-label prescriptions. Off-label meaning you have an antidepressant and you give that antidepressant for some other indication like, well, it happens all the time now in various areas. Antidepressants aren't a good example, but there are examples of medications that are used off-label and probably shouldn't be. Well, what does it mean to say somebody has a substance use disorder or a substance abuse disorder? Just in the last year, the DSM-5 was released, and this was the first version of the DSM that had come out in about 20 years. And in the previous version, there were multiple terms that were used, and this version, everything was collapsed into substance use disorders. So there would be an alcohol use disorder, cocaine, whatever the substance is, it's called a use disorder. That means a maladaptive pattern of substance use leading to clinical impairment as manifest by 2 or more of 11 criteria in a 1-year period of time. This is the comparison. DSM-4, actually DSM-4R, the revised version, is what I'm showing here. Abuse and dependence. There were 2 categories. You could be an abuser, and you could be somebody that was dependent. That would be synonymous with addiction. And in the DSM-5, the team that put together the new DSM-5 analyzed everything that was in the original diagnostic criteria from the DSM-4R and came to the conclusion that abuse and dependence were sort of an artificial separation based upon the severity of the disorder. Hence, they combined the category, the various criteria into just this one substance use disorder. These 4 that are in blue were in DSM-4 and related to abuse, and these that are in white were in DSM-4, and if you had these diagnostic criteria, that put you in the dependence category. DSM-5, however, takes all of the relevant criteria and puts them into 11 symptoms, if you will. The one that they left out is this was really not very relevant to diagnostic criteria, so they took out legal problems, and so that's not included. So there are 11 symptoms, and the 11th symptom is something that was not in any of the previous DSM-4. Everybody knows that people crave. They want their drug when they can't get it. They want their food when they can't get it. Whatever it is, craving happens. It's very difficult to find an operational definition of what that means. And so for years, it was left out of these criteria. However, they've diagnosed it now, and it is now included as one of the 11 criteria, the existence of craving. The other aspect of it is that DSM-5 now indicates specifiers. So you might have 5 out of the 11 criteria, and then they're evaluated for severity and physiological dependence and course. So severity can go from moderate to severe, with or without physiological dependence, meaning that an individual, if they cease the drug, would go into withdrawal, and they would have a withdrawal syndrome. So it's not a necessary criteria to have withdrawal, but it's a specifier that indicates a certain level of physiological homeostasis has been changed. And the last one is course. Is there early full remission, early partial, sustained full, or sustained partial? So the diagnosis includes those 11 criteria and then a specifier that goes along with how serious or how severe the disorder is. If you look at the prevalence, there are a lot of prevalence data of substance use disorder. So we're sort of in this transition stage. So I'll show you DSM-4 because most of the data that have been published so far have all been based on DSM-4 diagnoses. And you can tell that because there's alcohol abuse without dependence, alcohol dependence. And if you'll recall, DSM-4 had abuse and dependence. So if you look at this 2005 test, Rich Kessler is one of the main epidemiologists in this region, and when he does a study of this sort, pretty much every 5 years, he's looking at hundreds of thousands of records and surveying hundreds of thousands of people. So the data indicate the level of abuse without dependence at 2.5% in a 12-month period, and for a lifetime of 9. So you can see that, you can see these percentages, and what I think is very meaningful is that in the data sets that he evaluated, this most recent one was 2005, any substance abuse or dependence, there was 26% of people in their lifetime that exhibited DSM-4 criteria for substance use disorders. So we're talking about, from a healthcare perspective, we're talking about a pretty significant number of people that can show up in clinics, hospitals, and emergency rooms. Now, who are those individuals? When we think of a drug problem, we think what? We think young people. We think partying. We think a lot about that category of individuals, and we worry about them because individuals that are young doing drugs are challenging the function of their body and their brains. However, what is becoming pretty clear right now, over the last few years, is that we're dealing with an increasing drug use in older populations. This is just one example. This is the use of 3 or more prescription drugs in the past 30 days, separated into males and females, starting in 1988, extending into 2010. This is from the CDC as well. And you don't have to really look too hard to see that the percent of men 65 years and over that are using 3 or more prescription drugs is going up. Not all of those are necessarily psychoactive, but there's probably at least one in there that is. And in females, there's the same trend. So this is in 65 years and older. This is captured the attention of the federal government, of clinicians, and others around the world who are looking at these numbers, getting quite concerned about this shift in 8 years in this population. And while this previous slide showed you prescription drugs, this is a cartoon suggesting that, can you recommend a wine that goes well with seafood, Zoloft, and Lipitor? So I'm mostly talking about psychoactive drugs, but in reality, psychoactive drugs that are legal, illicit, like alcohol, does interfere with the function of the pharmacological function of lots of other medications. And as more and more prescription medications are taken by individuals that are older adults, what is going on here? This is just a table of some of the compounds, and these 2 sets of compounds are some of the most problematic psychoactive drugs in older adults. Benzodiazepines that are used for anxiety and insomnia. I'm sure you've all heard of Xanax and Valium and Dalmane and Ativan. This is a large category of drugs, a few of which are here. And then common opioid analgesics that are used for pain: codeine, oxycodone, hydrocodone, morphine, and nocaridine, fentanyl, tramadol, and methadone. This is not even all of them. These are 2 of the largest categories of prescription drugs that are given to older adults, and they're given frequently together. So they're taking medications that are on their own have a high degree of abuse liability and taking them together. So there are there are a lot of population demographics going on, work going on right now to try to identify how big this issue is. But these are the compounds that that SAMHSA have identified as a real challenge: the benzodiazepines and opiates. They all have high abuse liability and therefore an addiction potential. they interact negatively with each other and with alcohol, and the negative consequences can be quite severe. So in an emergency, if you look at older adults, categorized past 55, and look at the emergency department visits, 43.5% involved opioid pain relievers, almost half of them. 32% involved benzodiazepines and/or other sedatives, and that could potentially mean that they were mixing these drugs. So if you then can look at the impact on the function of older adults, they're pretty significant. So benzodiazepines in older adults are associated with cognitive confusion, a greater degree of falls, hip fractures, depression, and cognitive decline. Opiate analgesics, on the other hand, excessive sedation, even respiratory depression, impaired vision, attention, coordination, and also falls. So taking these two together are pretty serious. And if you want to fast forward to many, many months and years of taking multiple drugs like this, you can think about amotivational syndromes, memory deficits, difficulties in the families, decline in their natural health and their ability to groom and keep their hygiene, and then they could go into serious withdrawal from terminating these drugs. So part of what we do and what we're interested in is understanding the risk profiles and what actually sets up individuals for risk of substance use disorders. If we take it down to the brain, the level of the brain, we have a template of nature versus nurture, genetics versus the environment. And when a drug is initially taken, that drug starts off, generates subjective effects that induce an intoxication. If that intoxication is perceived as positive, that could be because pain is relieved, that could be because anxiety is relieved, or it can be because of a euphoric effect or a high. That can result in reinforcing effects. And when I say that, I mean that they're positive. The positive nature of that experience means that people will continue to try to take that drug, and it begins the cycle of use for the positive and subjective and intoxicating euphoric effects. That can lead to a loss of control, and there are many factors that contribute to that loss of control. At some point, if an individual begins to explore termination of drug use, there may be a withdrawal syndrome, which in itself can be very negative and drive the potential to seek drugs again. And ultimately, we're balancing between recovery and relapse in somebody that is trying to terminate drug use. This is all based in the brain, and we think about reward circuits. We may start taking a drug because a drug is rewarding. That drug feels good, and the reward circuit of the brain is known as the VTA, ventral tegmental area, to nucleus accumbens dopamine system. This pathway is phylogenetically old. It's in many, many organisms, and it's activated by what we need to survive with: food, sex, other positive things in the environment. It also happens to be that drugs overtake that system and essentially hijack it. So we've known about that system for a long time, but it's not only, addiction neurology is not only about the reward circuit. Learning and memory centers like the amygdala and the hippocampus, these circuits are now known to be very important in the maintenance of drug use. And this circuit, once impaired, can be impaired and remain impaired for many, many years. The best way of analyzing this is with functional magnetic resonance imaging, fMRI, and there's a great deal of data that come out about the involvement of this circuit in persistent drug-seeking behavior. Another circuit that's involved is the orbitofrontal cortex and the subcallosal cortex. These are considered drive and motivation centers. They interface with the reward circuit and the learning and memory pathways to contribute to the continued use of drugs. And one that we're very interested in is the inhibitory control circuits that are neurobiology, we're not just talking about reward, we're talking about cognitive pathologies in the cognitive circuits and pathology in the learning and memory circuits. And how do you, if that happens, how do you reverse that? So one of the aspects we always have to think about is the fact that lots of people try drugs. People have tried drugs for thousands and thousands and thousands of years. But only a small percentage of those individuals actually have a problem with it. In other words, they become dependent or addicted. And this is because of a balance of risk and protective factors. And this is a figure demonstrating that individuals who ever met, who have taken alcohol but meet criteria for dependence or addiction, it's only about 11% alcohol, 21% tobacco, 4 for marijuana, 4 for cocaine, and about 7 for heroin. So why is it that some of us are resilient and others are vulnerable to the development of addiction? This is because, we believe this is because there's a balance of the risk factors and the protective factors, and I'm not going to go into it, but for each of these risk factors, we're beginning to understand the circuits that are engaged in the brain to control those risk factors. We're also beginning to understand some of the genetics of these kinds of risk factors and how they control behavior. So high impulsivity is an example of a risk factor. High stress reactivity, high novelty seeking, and a negative emotionality, whereas the opposites are protective factors. So if an individual has robust inhibitory control, they don't respond to stress very significantly, or not high novelty seeking, and have a positive emotionality, they're somewhat more protected. The work that has been done in this region in this area has been a combination of looking at siblings or twins, one of whom or both of whom have problem with substance use disorders, functional imaging, and evaluations of behavior. So I just wanted to show you this as a cartoon of the idea. The normal controlled brain has a balance of lower risk factors and greater protective factors, whatever those are, and functions to stop impulsive responses to take drugs. That's a control subject. If you look at the siblings and their addicted siblings, this is Karen Ersch and Nora Olkow's work. If you compare a sibling to their addicted sibling, you find that these individuals are much more impulsive than the controls, but the addicted siblings are even more impulsive. So what you find in the sibling is the suggestion that there is a level of risk factors, however, that there's a level of protective factors that balance it and allow an individual to stop impulsive responses and taking drugs. Whereas in the addicted sibling, either because they have high impulsivity to begin with, or the drug has impacted the brain in some way to cause them to have higher impulsivity, that their risk factors are now high, they're imbalanced with their protective factors, and they're unable to make a decision to stop impulsive responding. So this is the example, and this is being parsed out with these technologies, with functional imaging, with behavioral tools, and ways of analyzing, normalizing, and risk factors in these populations. So if I go back to this cartoon, there's evidence to suggest that the trait of impulsivity actually can drive initial drug use, and the trait of impulsivity can also drive relapse in vulnerable individuals. And I have a couple of studies here to give you an example of this. Ralph Tarter has published 2 or 3 studies along the lines showing that levels of impulsivity predict the early onset of substance use disorder. In this particular study, the investigators analyzed levels of impulsivity using a scale, the Barrett Impulsivity Scale, at the age of 16. And they were able to predict substance use disorders by the age of 19 with 85% accuracy. And the levels of impulsivity were stronger. That correlation was much stronger predictor than the drug use frequency itself. So it didn't have as much to do with how much drug they'd done between the initial trait that drove them to use drugs to begin with. In an older population of patients, impulsivity also predicted opiate misuse in chronic pain patients. So there are 42 patients here, all of whom had experienced chronic low back pain for many years, and they were treated with an opiate. Their average age was about 48 years old. The investigators used the same scale I just showed you, adapted in the previous study for adolescents, and this was the adult scale, and then measured using a validated scale, measured opiate misuse in that group of people. They found that impulsivity is a risk factor for opiate analgesic misuse. So an individual that's highly impulsive is an individual who is misusing medication is also impulsive. So the vulnerability traits for addiction to begin with and for relapse are two aspects of the balance between risk and protective factors. And we're only beginning to tap into that right now. So one of the words that I've used probably half a dozen times, if not more, and one you'll see all the time, is the use of the word addiction. Addiction is is not a term that's used in DSM-5, but to relate it to what I've been talking about, it would be a severe form of substance abuse disorder, would characterize addiction. Go back to this table. I've just whited out the DSM-4. Again, there are 11 criteria that are used to identify substance use disorder, and these 11 criteria, it takes 2 out of the 11 criteria to be diagnosed with substance use disorder. However, if it's a severe substance use disorder or addiction, we now know more and more about the biology behind the persistent behavior. So this would be the most severe substance use disorder. We now consider it a chronic brain disorder, and it has significant compulsion to use drugs, even though an individual knows it's a bad idea. They know it's a bad idea, so they think they know it. But there's a compulsion to use the drug, even though there are significant negative costs. There's probably a whole group of debilitating disorders that have multifactorial origins that we could lump under addiction. But one thing that is common is that we know that continued use of the drug physically alters the structure of the brain, structures of neurons, and also the function of those neurons. That can take many years to recover. I thought it was best stated by the American Society of Addiction Medicine. Addiction is not about drugs, it's about brains. It is not the substances a person uses that makes them an addict. It's not even the quantity or frequency of use. Addiction is about what happens in a person's brain when they're exposed to rewarding substances or rewarding behaviors. And it's more about reward circuitry in the brain and related brain structures than it is about external chemicals or behavior that turn on that reward circuit. I find this a meaningful sentence because it doesn't focus so much on the drug, it focuses more on the behavior of the individual. And it's the behavior that is problematic, and it's represented. The second feature is that it is the brain that's driving behavior and the behavior that changes the brain. So there are many looping processes that are going on in a brain that is exposed to drugs and the behaviors associated with it. So one way of thinking about it is I introduced you these brain areas a moment ago. In the normal brain, each of these circles indicates the normal function of that brain. So the nucleus accumbens, which we know is the primary terminus of dopamine neurons in the reward circuit, it drives how salient a drug is or how salient the experience is. That drives the orbital that projects to the orbital frontal cortex, which is involved in the drive to take drug. Then we've got the judge and jury in the prefrontal cortex that is controlling this drive, when and where the drive is appropriate. And then the memory circuits in the amygdala and the cortex. They're all working in concert with each other. And the optimal outcome is that it's possible to stop or not start drug use. However, in the addicted brain is different. So the saliency, the red circle that indicates saliency in the nucleus accumbens is much larger. Drugs have a much larger control over behavior. It's an incentive to take the drugs. The drive is much greater. The control is much smaller, and the memory is much larger. So there's an imbalance in the addicted brain that is actually driven by structural changes. This is a PET image. This is a normal brain, and this is an addicted brain, and the actual glucose utilization is reduced, and this is a month after the termination of drug use. So this situation actually results in the continued use of drugs. So how do we convert this addicted brain into a normal brain? We do know, if we think about this the way we're thinking about it now, and I can give you lots and lots of data to support this concept. We now know that drug abuse is preventable. Drug abuse is preventable. That drugs change biology. Drug abuse and addiction are treatable, and if untreated, it can last a lifetime. And we have to think about it. We need to reset our brains and start thinking about drug abuse and addiction as a chronic disorder. And it's not that dissimilar from other chronic disorders. So this is actually brain metabolism, glucose metabolism in the brain of a normal control individual. This is an individual who's been a long time cocaine user, and you can tell that there's a reduced level of brain metabolism in this cocaine-dependent individual. If you compare these two, this is a healthy heart, and this is a diseased heart, and this is actually a reduction in heart metabolism in a heart disease patient. So we can think about this disorder along the same lines, and in some people it's possible to just say no, in some people it's possible to just stop. In other people, it's not. And so for those individuals, we need to think about how to best deal with the biology of the disorder, the neurobiology of the disorder, and come up with the best treatment modalities. So if you think about addiction across the lifespan, the first thing to know is work that's been done, huge epidemiological studies over the years that have been done by the federally funded projects have identified that addiction is a developmental disorder. Most that have an addiction diagnosis begin drug use early. So about 97% of the individuals who seek treatment for drug abuse began their drug use before the age of 21. Only a smaller proportion, 3.5%, were over 21 years. That actually may be changing now, and I'll come back to that in a minute. But I don't want to, in talking about older adults, I don't want to diminish the importance of thinking about the use of drugs in adolescents. Adolescents have brains that are in the process of development. This is a series of brain images from the age of 5 to the age of 20. And these images were, this work was done over, this work was done over a 15-year time by the UCLA imaging group. And they were looking at healthy children as they grew into adults. And then this is a composite of a whole, I don't remember the N on this, but there's something like 30 kids in this study. What's noticeable, this is just a side, and this is the top view of the brain. What's noticeable is in a 5-year-old, there's all this red. The red and the yellows predominate over the greens and the blues. That indicates an immaturity of pathways into the cortical structure. And as the child moves toward the age of 20, you see a dramatic change in that now the brain is changing from these red and yellow colors into blue and a little bit of green. And what's extremely notable is the fact that the cortex, this is the prefrontal cortex that I've been telling you about, is now completely demonstrating a completely different structure of neuronal innervation. This developmental process from children to the age of 20 has now been pretty well characterized as critical to pruning neurons in the brain and making sure that the cognitive areas of the brain are developing executive function correctly. So children and teens are not little adults. And this is something that we need to think about when we're thinking about prevention, when we're thinking about treatment. It looks like addiction begins in adolescence. They're not little adults. And the brain architecture and how everything's put together is changing through adolescence. So that means that the ability for individuals of that age to integrate all the information they have to integrate at that age is not fully developed. So particularly executive function. Executive function is inhibitory behavior, inhibitory control, and it matures latest. Another factor that I don't have time to talk about is the heritability of abuse, liability, and addiction, and how that fits into the picture of prevention in adolescence. So we know a great deal now about the start of substance abuse. We haven't converted it very well to prevention. I think we've got a great opportunity there to move into prevention science. Now we're interested in looking at what is going on in older adults. So there's a great deal of information that's shown up on the in the literature as well as the internet, and these are just some of the images that I took from the internet. This might be of interest to those of you who are social workers. They had a volume, and I've got it at the end, The Changing Face of the Older Adult Substance Abuser. And in fact, that's what that whole changing face idea, I like the concept, which is why I retitled my talk. So these are data that were just published in 2011 in the Journal of Geriatrics Psychiatry. This is treatment, first-time treatment admissions, younger versus older adults. So these are 30 to 55-year-olds and older than 55. And this is when they come into treatment, what drugs did they mention? So there's a balance in this age group between alcohol and drugs only between 1998 and 2008. What's interesting here is that in the older group, alcohol has been declining, but the combination of drugs with alcohol and drugs only has not, and it's a very different pattern than what's seen in slightly younger individuals. If you take apart these percent drug mentions in treatment admissions for older adults, and you compare, again, younger refers to the 30 to 54, and I think the older group is 55 and older. The black line is the oldest group. This is alcohol mentioned. In between 1995 and 2010, it's about 80% of them mentioned alcohol, and that is declining slightly. In the younger group, there's less alcohol mentioned, and it is also declining. This pattern is significantly different than what surprised these investigators tremendously is the illicit drugs. So this is cocaine. You can see that there's not as significant of mentions as for alcohol, but the younger group is running about 30% across until about 2005, and then it dropped, but there's still about 25% of them reporting cocaine use. This was the real surprise. The rise in cocaine use across time in the oldest group. Totally and completely unexpected. This may not have been as unexpected, and we'll talk about that in a second. Marijuana, about 25% in the younger group, it's been sustained, but the older group of individuals, it's also rising. And heroin mentions, you can still see the scale here is now changed again. This is the top is 20%. The younger group is around 10%, but look at the increases in the older group. So these are illicit drugs. These are not prescription drugs. These are illicit drugs. So this was the concerning aspect of this analysis. So their data indicated that when individuals showed up in treatment, the proportion of older adults in their first-time treatment is increasing versus younger adults. alcohol remains the primary problem drug, but there's increasing illicit use reported in this older population with cocaine, heroin, and marijuana, the three top compounds. The CDC reflected about this possibility, suggesting that the trend reflects the aging of the baby boomer cohort, that is those born between 46 and 64, which is the younger group, whose rates of illicit drug use have been historically higher than their older controls. And nobody's proven this hypothesis, but it makes rational sense to me. And this version of this issue of social work took it a little farther and put it within the cultural context that the baby boomers grew up when illicit drugs were widely available. There was greater acceptance and experience with illicit drugs and prescription medications that did not exist in the older group that's currently past in their 60s or higher. They went on to suggest other possible explanations, also not founded in any real epidemiology or science. Economically, this age group of individuals can exhibit high anxiety about job security and retirement savings. If you're past retirement age, that's less of a problem. And emotionally, it's not uncommon for individuals that age group to cope with grief and loss, like the death of a spouse or the end of a career. So there are lots of hypotheses about it. None of them have really been tied to the population that is discussed. So what about risk and protective factors? This is an evolving science. In the last few years, SAMHSA has been pulling together these risk factors and protective factors. And the risk factors are male, racial and ethnic status, higher social economic status, lower social support, a previous history of problems, and a previous history of drug use in general. Whereas protective factors include being female, having fewer mental or physical problems, a lower socioeconomic status, positive coping skills, and more social support. So these kinds of factors are potentially important in whether or not an individual is self-medicating or taking more of their medications than they should. This whole issue of whether or not an individual is abusing substance at a later age in life, changes the way diagnosis needs to occur. And this has not been considered in DSM-5. For instance, tolerance in older adults, the biology of the liver and other systems in the body, it seems to be that even low intake can cause problems because of those changes. That we don't handle drugs the same way the older we get. Withdrawal may not be the same. People may not develop physiological dependence. If they use in larger amounts than they should, then cognitive impairment can be much worse and interfere with self-monitoring. And there are other examples of this. I think one of the most interesting ones is that this whole concept in DSM-5 that you use despite your knowledge of problems, if you're cognitively impaired, then you can't recognize the depth of the problem. So it's a cycle that is ensuing. What time is it? I don't know my watch. It's 2. Are we done at 2?
1:58.
Do you want me to finish now? I have a few more slides, but.
Because I had 9 minutes.
Oh, yeah, you did. So let me just finish with a little bit about treatment. Yesterday we thought of addiction as a moral failing. That was the main problem. And we didn't have the technologies for studying addiction. Behavioral therapies were in their infancy, and we didn't have any medications that were available to support recovery. So now we know that we can't ignore the whole person. We have to think, we can't just think about the fact that a person is taking a drug. We have to think about how are we going to support them in all their arenas. That includes behavioral therapies, it includes medications, medical and social services that all support the social context of the individual. So treatment doesn't happen in a void. Tomorrow, what I'm optimistic about in the future is that we're transforming prevention and treatment. We're on the verge of being able to think through how to personalize medicine for addiction. The studies that have come out suggest that genetics may actually account for about 50% of the risk of using drugs. We need to integrate behavioral and medication support for recovery. And from the perspective of being a laboratory scientist, we need to guide the discovery of new science, new treatments based upon our knowledge of addiction biology. And then from the perspective of the clinical arena, we need to improve the access and delivery of care for addiction and health concerns. Lots more people need treatment than get it. And if we can even nip that in the bud and prevent it to begin with by routinely screening patients to prevent the initiation and escalation of the disorder, that would even be ideal. So this is a large task, but we do know that even though this can be a fatal syndrome, it's chronic and relapse, it's not a moral failing, and treatment can be as successful as for other chronic disorders. So studies have shown that you can decrease drug use by, if you can decrease drug use by 40 to 60%, 100% would, maybe even be better. Criminal activity decrease, the risk of transmission of infectious diseases decrease, and the prospects for employment increase. So there are lots of outcomes, positive outcomes to successful treatment. And partly the problems that we encounter with resetting this malfunctional brain is it takes a long time. It appears that, at least from the perspective of George Koo, that the compulsive drug use and loss of control results in these neuroplastic changes that accumulate. It's like you add damage on top of damage, and it's important that these systems have to recover. And to say it in one single sentence, the addicted brain is not the normal brain. If the addicted brain is not the normal brain, how long does it take to become the normal brain again? Now, one measure of that might be looking at sustaining recovery. This is the duration of abstinence at 7 years. And what these investigators found is that if they could retain someone in treatment, it takes a year of treatment for more than 50% to stay abstinent. So it takes a minimum of a year, that's 1 year. But if you really want to maximize recovery, then you're talking 3 to 5 years or 5 years plus. So if you're sober by this point, then you're probably going to stay sober. 5 years of treatment, 5 years of consideration for treatment. And unfortunately, while we know that we can save lives and decrease long-term costs, and that treatment can be as effective for other chronic conditions, and particularly we now know that about 72 medical conditions are reduced if an individual can stop taking drugs, and the benefit to cost ratio is about 7 to 1. The problems are that the cost is too high or the therapies are inaccessible. And so these two barriers are ones that we need to deal with. Another more long-term barrier is that we don't do as good a job as possible tailoring the therapeutics to the individual. Here's the problem in a nutshell. So only about 10% of those diagnosed with addiction, not including nicotine, but diagnosed with addiction, actually received treatment in 2010. Compare that to the number that have major depression, diabetes, and hypertension. About almost 71 to 80% receive treatment. So these individuals are not receiving treatment. There are volumes now. This is one of the nicest volumes I've read on the principles of drug addiction treatment. It's actually it's more like a pamphlet that's available online. There's no single treatment appropriate for all patients, and it needs to be readily available. As I mentioned, the motivation for a drug user to quit, their behavioral inhibitory capabilities is not maximal, so there needs to be treatment that's readily available. It attends to multiple needs of the patient, and it may take multiple courses of treatment for success. And also, as I mentioned, remaining in treatment for the adequate period of time is critical for effectiveness. So we know it can happen. And there are many different psychotherapies to return a brain to a non-addicted state. And these, you're probably familiar with contingency management, cognitive therapy, motivation therapies, biofeedback, behavioral therapies, and relaxation are examples. These are not maximally effective, and so we need to be able to develop ways to maximize their effectiveness. But recovery is hard, and we need lots of tools. We need this big, giant toolbox to provide what's necessary for a larger number of patients. And if we have available medical treatments, that also encourages doctors to treat patients that have problems with drugs, just as in other areas. It's a little harder in this area, but if you find somebody has a high cholesterol level, then you treat them. And you try to bring that cholesterol level down so that they improve their health. It would be nice if we could have something simple like that, but that's not the case right now. Nora Volkow recently published a commentary in which she was talking about how to sustain recovery. And this is a quote from that commentary. You're killing two birds with one stone, giving tools to improve outcomes for patients and tools to physicians, increasing the likelihood that treatment of substance use disorders will be incorporated into their practice. And the reason this is the case is you may have some examples from your practice in your areas, but the study that I like to quote the most is a study of 12,000 primary care physicians that was done a number of years ago, who only believed that 4%, only 4% of them believed that treatment for drug use and addiction worked. Okay, that meant 96% don't believe treatment worked. If you're a primary care physician, if you don't believe that treatment works, why would you try to diagnose it, and why would you try to do anything about it? So that is my fault. I'm sorry, that's my fault. I've been teaching physicians and healthcare people for years, and I haven't gotten this idea that we can sustain recovery and to pass down through the ranks. So I'm hoping that you'll recognize that there are not only behavioral therapies, but there are also pharmacotherapies that can help ease the transitions for individuals who are suffering from abuse disorders. Unfortunately, we lack any for cannabis and we lack any for psychostimulants, but there are pharmacotherapies that can be used in adjunct fashion with psychological therapies. And there are many, many more on the horizon. In the concept of changing the addicted brain to a non-addicted brain, there's work going on in laboratories all over the world to try to reduce and prevent relapse by interfering and creating new memories. There's just many, many strategies that are under investigation. So hopefully today, I've given you a sense of the prevalence of this problem, given you a sense of the corruption of key brain circuits that we normally use for our daily behavior, but they get transmuted into those for addiction. There are pathologies in the brain, pathological changes in structure and function. And a modern perspective is that the trends in drug use in older adults is changing sort of the thought pattern of how to deal with that. That vulnerability factors that put individuals at a risk have to be maximized, reduced, and risk factors maximized, protection factors maximized. And then the whole idea that we might be able to promote the control over psychoactive drug uses with the combination of psychiatric therapies, psychological therapies, and medications is a much more modern perspective. So I sent the presentation to, I think I sent it to you, Rachel. Sent it to Rachel. This is a document that is on that presentation. It's called Older Americans Behavioral Health Series, and has many, many resources to learn more about the issue of substance abuse in older adults. So thank you very much for your attention. All perfectly muddy, right?
Are there any questions from the remote sites?
Oh, come on. There's nothing worse than spending hours working on a talk and nobody wants to know anything. Come on, ask me a question. Noel.
Well, you are
Yeah.
Simon.
So with the issue with the new Affordable Care Act and how that might be changing Medicare and getting the older generations who are moving into Medicare for their treatment, what are the plans in place for diagnosing and treating the elderly if we're having this increase in illicit and illicit drugs?
There might be somebody here that's better at answering that question. I mean, from a general perspective, I know that the Affordable Care Act is promoting prevention on the front end and is also promoting the concept of medical homes so that you're coordinating the care of an individual. I think what happens when an elderly person sees I know this from my mother, they see 5 doctors and they're getting stuff, and some of them are psychoactive, not even all of them are psychoactive, they're getting 5 or 6 drugs from all different sources, and nobody's actually the point of contact that says, oh, wait a minute, bad idea. You don't want to do this, you need to do this. And so that's what I'm hopeful that would alleviate some of the issues. There are also contracts for psychoactive drug medications. That's spreading a lot now. Opiate, I think everybody that uses OxyContin or a compound like that has to sign a contract that says they will not abuse their drugs. They get 30 days of medication or whatever it is. They can't get any more. So that's part of it. But I don't know. Does anybody else have any insight into what might happen down the line?
Part of the issue, though, is if they don't go to the same pharmacy.
Yes.
Yeah, so hopefully, you're thinking that, if they're on 5 drugs, there's a pharmacist who will stop and say, wait a second. But if they're going to CVS for one drug, because it's a $5 prescription, and then Walmart for another drug, because it's a $5 prescription, and they're going to multiple places, there's no stop point to say, wait a second.
I believe hasn't that changed for drugs like OxyContin though?
Oh, yeah.
That's all on some sort of national database now that you can track that. But that doesn't answer the question, total question, you're right. Claudia?
So treatments for addiction, are those going to be dependent on the person deciding that they want to quit? Or do you foresee treatments possible before the person makes a decision?
They may not be able to make that decision.
Right.
They may be in prison or jail before that decision's made. So the drug and mental health courts, I think, are good examples of how to motivate an individual that is not in the place to be motivated. If a judge sits in front of a podium and says, you need to do this, such, and that, and you have to show clean urines every week for the next 6 months or you're going to prison, that's a motivator. Now, is that enough of a motivator for everybody? Probably not. So the question becomes, how do you have an individual motivate themselves to stop using? And early on, it's easier. So people make lots of quit attempts. It's not like somebody becomes a street, living on the street as a heroin addict. That can happen extremely rapidly, but it usually takes stages, and people will try to stop, and then they relapse. And their family tries to help them, and then they get tired of it after 2 or 3 times. It's a complex problem. Smoking is a really good example. How frustrating that is for people who have smokers in their family. Just quit. And they try, and they try, and they try, and they go back to it. And that's probably, one of the biggest problems we have in the world. So I don't know the answer to that question. You have to be motivated or it's not going to work. But what's the motivator? Your wife is going to leave you, you're going to lose your kids, you're being shoved out of your house. I mean, there are lots of motivators. Brianna?
Just for clarification, you showed a figure that I think was the rate or the amount of older individuals using 3 or more prescription drugs. I don't know if what kind of prescription drugs are we talking about, like psychostimulants or?
They could have been they're just prescriptions, but they typically did have at least one psychoactive in there. So it could be blood pressure medicines, benzodiazepine for anxiety, and Lipitor. Yeah. So it wasn't just psychoactive drugs. All right.
Well, thank
Thank
you
you
very
very
much.
much.